One may suspect an underlying autoimmune connective tissue disease when a patient presents with arthralgias, fevers, and other systemic manifestations. And a connective tissue disease is often a differential diagnosis when autoimmune arthritis is suspected. There are four main types of autoimmune connective tissue disease: systemic lupus erythematosus, or SLE, or simply lupus, Sjogren's syndrome, autoimmune myositis, namely dermatomyositis or polymyositis, and systemic sclerosis, otherwise known as scleroderma. Lupus is the prototypical autoimmune disease where the immunopathogenesis involves a breakdown of almost every part of a normal immune system, leading to systemic autoimmunity. Disease onset is typically in young adulthood, and it affects females much more commonly than males. In terms of arthritis, it typically affects the small joints of the hands and feet, but differs from rheumatoid arthritis and the other autoimmune arthritides in that it typically doesn't cause significant erosion. Instead, you can get a hyperextension of the metacarpophalangeal joints, known as Jacquard's arthropathy. Because lupus is an autoantibody immune complex mediated disease, it can lead to several systemic manifestations, including a rash, particularly a photosensitive rash, known as a malar rash across the face, but also an erythematous macular rash, known as cutaneous lupus. There can also be aphthous ulcers, particularly affecting the oral mucosa, and non-scarring alopecia. A renal manifestation of lupus is that of lupus nephritis, which is a nephritic syndrome and can lead to potentially severe renal failure. There can also be associated neuropsychiatric manifestations, known as neurolupus. Cytopenias, particularly anemia, can also be present, which is due to multiple different mechanisms. Serositis, such as pericarditis, is also associated with lupus, as well as the other autoimmune arthritides. Lupus is also associated with a type of thrombophilia known as antiphospholipid syndrome, which can be investigated for in the context of an unprovoked thrombosis by looking for the presence of lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. In terms of autoimmune serology, lupus is almost always positive for anti-nuclear antibodies, where a homogeneous pattern may suggest the presence of a lupus-specific autoantibody, such as the anti-dsDNA antibodies or anti-histone antibodies, which are typically seen in drug-induced lupus. A speckled ANA pattern may also be observed if the patient has an anti-Smith antibody, which is also very specific for lupus. The ANA test looks for the presence of these anti-nuclear antibodies and reports it as a titer with a particular pattern, such as a homogeneous pattern or a speckled pattern, and those patterns then suggest the presence of other autoantibodies, which can be looked for in the extractable nuclear antigen screen or the ENA screen. So in the example of lupus, the patient may have a high titer homogeneous ANA pattern, where the antibody causing the homogeneous pattern is dsDNA, and so the patient will also have a very high level of dsDNA. But because dsDNA is not part of the ENA screen, the ENA screen will come back negative. Alternatively, the patient may have a high titer speckled ANA pattern, which would suggest the presence of an autoantibody which produces a speckled pattern. And so the ENA screen may then come back positive for anti-Smith antibody, which is part of a typical ENA panel. And such results would also suggest that the patient has lupus. I will mention the common ANA patterns and ENA antibodies throughout this video series. The next autoimmune connective tissue disease to discuss is that of Sjogren's syndrome. Disease onset is in middle age, and like lupus, it also has a female predominance. The arthritis component of Sjogren's syndrome can be variable and affect small or large joints, but the hallmark of Sjogren's syndrome is that of sicca symptoms. where the autoimmune destruction of the lacrimal glands and salivary glands leads to the symptoms of having dry eyes and a dry mouth respectively. Like lupus, there are various systemic manifestations, including thyroiditis, interstitial lung disease, cardiac involvement, and renal involvement, including tubular interstitial nephritis and distal or type 1 renal tubular acidosis. There can be neuropsychiatric manifestations, primary biliary cirrhosis, and cytopenias, much like lupus. Other hematological manifestations include that of a monoclonal gammopathy and associated lymphomas, particularly the mucosal-associated lymphoid tissue or multomas. There can also be an associated type 2 or mixed cryoglobulonemic vasculitis. The diagnosis of Sjogren's syndrome can be made if there is objective evidence of glandular parenchymal damage or objective evidence of the sicker symptoms, such as a positive Schirmer's test where there is less than 5 mm per 5 minutes of tear flow, along with the presence of consistent autoimmune serology, namely a high titer speckled ANA pattern, as well as either anti-Rho or anti-La, also known as anti-SSA and anti-SSB respectively, on the ENA screen. Sjogren's syndrome is also less commonly associated with an autoantibody known as the anti-centromere antibody, which has a centromere ANA pattern. The next autoimmune connective tissue disease to discuss is that of the autoimmune myositis, which is known as dermatomyositis if there's the presence of the typical dermatological manifestations. In particular, the heliotrope rash, which is a periorbital violaceous rash, Gottron's papules, which are small erythematous elevated papules typically over the metacarpal phalangeal joints, as well as the interphalangeal joints and sometimes the elbows as well, and the Shaw sign and Holster sign, where there is a erythematous rash across the V of the neck and the sides of the thighs, where a holster would be positioned. In the absence of these dermatological features, autoimmune myositis is known as polymyositis, which otherwise has essentially the same clinical manifestations, but has different associated autoantibodies. Autoimmune myositis typically has disease onset in middle age and also has a female predominance, like all the other autoimmune connective tissue diseases. The associated arthritis typically involves the small joints of the hands. The hallmark of autoimmune myositis is, as its name implies, inflammation of the muscle, of which clinical evidence includes that of proximal weakness, and biochemical evidence includes that of a markedly elevated creatine kinase or CK. Autoimmune myositis may have a positive ANA, particularly a speckled ANA, and a positive ENA, particularly JO1 in the case of polymyositis. It is also important to note that there is a myositis line blot or an extended myositis antibody panel, which can look for a number of myositis-specific antibodies which are not part of the ENA panel. Notable myositis-specific antibodies include that of MDA5, which is associated with rapidly progressive interstitial lung disease and a amyopathic clinical presentation, so the lack of proximal weakness, TIF1 gamma, which is strongly associated with malignancy, NXP2, which is strongly associated with calcinosis as well as malignancy, and MI2 or Me2, which is associated with the typical skin manifestations. There are also a number of antibodies associated with the anti-synthetase syndrome, of which JO1 is one of these antibodies. The anti-synthetase syndrome is a subtype of autoimmune myositis with the classic manifestations of arthritis, mechanic's hands, which includes fissural ulcerations, particularly on the lateral surfaces of the fingers, and Raynaud's phenomena, where affected patients can get painful discoloration of their fingers due to abnormal vasoconstriction of the supplying vessels. Vasospasm of the vessels supplying the hand will lead to initially a white attack where the fingers go pale, followed by a period of tissue hypoxia leading to cyanosis and blue fingers known as a blue attack. And lastly, upon resolution of the vasoconstriction, normal blood flow or reperfusion is achieved and the fingers become markedly erythematous. Raynaud's phenomena can also be seen in all of the other connective tissue diseases. The next autoimmune connective tissue disease to discuss is that of systemic sclerosis or scleroderma. This also tends to affect females more than males and has a disease onset also in middle age. The hallmark of systemic sclerosis is that of skin thickening, where the skin loses its normal turgor and becomes hard and thickened because of skin fibrosis, hence the name scleroderma. Systemic sclerosis can be divided into two main subtypes: diffuse cutaneous systemic sclerosis, where the skin involvement is proximal to that of the elbows and knees, or limited cutaneous systemic sclerosis, which is otherwise known as Crest syndrome, where skin involvement is distal to the elbows and knees. But there is usually the presence of the so-called crest stigmata, where crest stands for calcinosis cutis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasias. The arthritis involvement in systemic sclerosis can involve the small or the large joints. Associated extra-articular manifestations include interstitial lung disease, particularly in the case of diffuse cutaneous systemic sclerosis, which can later lead to group 3 pulmonary hypertension as a complication, or group 1 pulmonary hypertension, or pulmonary arterial hypertension, which is more associated with limited cutaneous systemic sclerosis. There can also be renal involvement, known as scleroderma renal crisis, and gut involvement, known as scleroderma gut. Systemic sclerosis is also associated with malignancy as well as venous thromboembolism, which is similar to the other autoimmune connective tissue diseases. In limited cutaneous systemic sclerosis, there's typically the presence of a centromere ANA pattern. In contrast, in diffuse cutaneous systemic sclerosis, there's typically a high theta speckled ANA pattern with a positive ENA screen for anti-SCL70. Like in the case for autoimmune myositis, you can also do a systemic sclerosis antibody panel to look for other autoantibodies associated with systemic sclerosis that are not part of the standard ENA panel. These include antibodies such as U1RNP, which is associated with mixed connective tissue disease, where there is an overlap of features across the connective tissue diseases, and PMSCL, which, as its name implies, is an overlap syndrome with features of both myositis as well as systemic sclerosis. So now that we've discussed the features of autoimmune arthritis and connective tissue diseases, we can go on to discuss the typical features of vasculitis.